I invite Dr. Luigi Di Biase for PVC-mediated cardiomyopathy diagnosis and management.
Thank you, Mr. Chairman. I would like to thank Dr. Lucky Reddy for the invitation in Kansas City. So the task I've been assigned is PVC-mediated cardiomyopathy diagnosis and treatment. So this, how does it work? These are my disclosures. So premature ventricular beats are frequently detected in the clinical practice. They can occur in subjects with either normal heart or with cardiac disease. With a few exceptions, their clinical significance is usually dependent on the burden, on the amount of PVC that we have during the day. We'll see why. If we look at the classifications, ventricular arrhythmia-induced cardiomyopathy definition, we see that tachycardiomyopathy are there, and if we try to understand what they are ventricular arrhythmias with a potential reversible cause of dilated cardiomyopathy, with a decreased global contractility and a decreased ejection fractions, symptoms of dilated cardiomyopathy following the onset of the arrhythmia, dilated cardiomyopathy which is reversible after treatment of the underlying arrhythmia, or the exclusion of possible other causes that may lead to the cardiomyopathy. If we look at this paper of 2011, you can see that here the authors in an animal model, they try to give ventricular pacing at different coupling intervals in these animals. And as you can see here, by increasing the number of, is there a pointer? Okay. By increasing the number of PVC, you see there is a decrease down in the figure. There is a decrease of ejection fractions, while when the PVC are stopped, the ventricular beats are interrupted. In 4 weeks, the ejection fraction equal the one of the control group where no pacing was given. And importantly, in this paper from the group of Dr. Asim Varatan, you can see that the number of PVC has a direct correlation with the decrease in ejection fraction. You can see on the left, less than 10,000, in the middle, between 10,000 and 20,000, and in the right, more than 20,000. You can see that the decrease in ejection fraction is much more when the number of PVC are higher, and this can be observed in evaluating just the total number of PVC, but on the right side of the figure, you can see the burden. So the amount that we have during the day, the percentage of PVC. So they both matters. And they also influence, of course, the dimension of the left ventricle, as you can see, the end diastolic diameter. This slide just summarizes what we have seen before. Of course, the number of patients that have a lower number of PVC are higher than the one that have a lot of PVC, but as you can see, when the number of PVC is high, the ejection fraction goes down. And this is just another paper showing the same concept, correlation between the frequency of PVC and the ejection fraction. If we can find a pointer, I will clear. This one? Okay, but was not. Okay, anyway. Another important concept from the same paper of Dr. Asim Varatan is that the site of the PVC does not matter. As you can see, right ventricular origin or left ventricular origin, they both they both here affect the ejection fraction in the same way. But if we try to understand which are the characteristics of PVC that may lead to LV exhaustion, so as we have seen, the burden, so the number of the PVC affects this. The QRS width may affect the left ventricular dysfunction. The site of origin, epicardial versus endocardial, not the right or the left. The presence of non-fascicular PVC, the presence of retrograde P wave, and interpolated versus not interpolated PVC. This is just a summary of which are the characteristics of this PVC that may affect the ventricular function. The number and the burden, in my opinion, are the most important. So which are the most important pathophysiological mechanisms that may lead to a tachycardiomyopathy? The abnormal AV activation sequence, the irregular VV intervals, and a kind of dysynchrony that can be activated by this PVC. In fact, the premature ventricular beats may affect the cardiac output, as shown here in this monodimensional echo, as well as they can affect and induce a kind of dysynchrony, pre-ejection, aortic pre-ejection delay. We'll see later that there are cases where the number of PVC affects the resynchronization without giving tachycardiomyopathy. But what's the solution for a high number of PVC inducing left ventricular dysfunction? We know that ablation, successful ablation, as shown here, can allow the ejection fraction to go back to normal value. And we know this from several series. This is a nice series of 2005 where all the ventricular beats were from the RVOT, and as you can see, all the parameters improved when the ablation had success. In this series, 93% success rate. Why? Because all the PVC were from the RVOT area. But several papers have been published. Here another one showing right ventricular outflow tract PVC that can be easily ablated with good results, and again excellent pre-ablation and post-ablation recovery of the ejection fraction. I would like to show this paper because of conflict of interest, since my father was involved in 1992. In these 26 subjects, we are talking about PVC that are present in normal heart, but endomyocardial biopsy showed that in 62% of the cases, they were pathophysiological, pathological findings that were defined as aspecific in 42% of the cases. So what we consider a normal heart, I don't think it's always the case. Myocarditis and other find of infection or start of disease may be there, but not all the time the heart is completely normal in patient experience PVC. This is a nice case that I got from a group in Italy, where it's a patient of 25 years old, volleyball player with fatigue and palpitation, frequent PVC, with monomorphic PVC with a left bundle branch block and inferior axis deviation with normal heart. As you can see, a lot of PVC. This is a typical RVOT PVC scenario, and as you can see here, the earliest activation here is during activation mapping and during pace mapping 12 of 12, and ablation in the RVOT area got success during with the termination of PVC during ablation, and at the follow-up repeat Holter monitoring, no PVC. So this is the easiest scenario because we are talking about RVOT. But is always the RVOT, the origin of this PVC. No, it's not always the RVOT. Actually, all possible scenario is possible in these patients because we can have RVOT, but pulmonary artery, cusp, LVOT, aortomitral continuity, papillary muscle, AV rings, epicardial origin, and coronary sinus and great cardiac vein. So the diagnosis and treatment was the task that was assigned. So not all the time the LBB with an inferior axis deviation is the case. We have to remember that there is an area here where things are not that easy because coronary cusp, great cardiac vein, and RVOT are very close to each other anatomically. And so if we think that things are easy to diagnose from the ECG, like this is a typical RVOT tachycardia versus this is a typical LV of three-tract tachycardia or PVC, things are not always that easy. Why? Because if we look at this schematization here, this is V1, this is V5, and so we can think that it's easy to differentiate the origin. But if we remember that the heart is not biplane, it's three-dimensional, so V1 and V5 actually will close to each other. So what is in V2 and V3 here and V4, it's very tricky because they will overlap. We are opening like a piece of paper, this diagram, but actually they touch each other because it's three-dimensional. So the ECG is very hard. In addition, when we place the lead during a regular ECG, is not always where we place the lead position in the EP lab. So during the ablation, and this is from the courtesy of Dr. Callans and Marciniski from the PEN group, it's sometimes we may be fooled about the origin of this PVC. And several criteria have been diagnosed on the ECG trying to address if it is an LVOT or RVOT tachycardia. This is from the paper of Kamakura in Circulation, and this also elegant study by the group of Dr. Kotkam trying to see the R to S transition. But again, all these criteria, of course, works if we place the lead in the right position, if we have typical cases, but sometimes the anomaly may be very tricky. In addition, many times these patients are under antiarrhythmic drugs, and the antiarrhythmic drugs may change the duration of the QRS, and so affecting all these criteria. Sometimes it's hard to understand if the PVC or the VT as having origin from the endocardium or from the epicardium. This is one of the described criteria to understand if the origin is endocardial or epicardial by looking at lead 1 with a positive wave and a negative wave in AVF, while from the epicardium it's negative in lead 1 and positive in AVF. But again, sensitivity and specificity may change. These are criteria instead described for ischemic cardiomyopathy. Again, the antiarrhythmic drugs may work or may not work. I just would like to point out again that so the ECG may fool us understanding where they come from, especially look at these cases where there is a close proximity between the cusp and the great cardiac vein here again. So of course, the ECG may tell us that it's from the great cardiac vein, from the coronary cusp. Actually, both of them may be necessary in some cases, we will see later, to address this PVC. Of course, another possibility is the presence of a coronary cusp PVC in this patient. As shown here, the presence of intracardiac echo may be very helpful. We presented a series in an abstract that has not been published yet. Unfortunately, Dr. Natale will be mad at me, where actually more than one site is necessary to achieve success for elimination of this PVC, because you have an early activation in one site, but still the PVCs keep coming back because we cannot reach the right area where the PVC is coming from. And so at least 2 or 3 sites that are close to each other are necessary to achieve success. And there are cases very hard like this where the appendage tip is necessary to achieve success of elimination of the PVC. So RVOT 93% success rate do not always match with the hard area where the success rate goes down, especially if the ablation is performed in a non-well experienced operator. So let's go to the treatment. The medical treatment with beta blocker, has a very limited efficacy anyway, which is lower than the ablation. So ablation is usually the best treatment in these cases. Of course, when the PVC are a lot, we have said that when the patients are symptomatic, where the PVC are giving a reduction of the quality of life with the, LV dysfunction, of course, and when anti-arrhythmic drug do not work. How to understand where this PVC comes from? Of course, the ECG is always helpful, and it has to be the point of start, but sometimes may fool us, as we have seen before. And the best way to address the site of origin of this PVC is an activation mapping, with usually an earliest ventricular activation, and the unipolar sigma may be important. And if the PVC are not frequent in the lab because we are using general anesthesia, for example, or because during the day of the procedures the PVC are not there, pace mapping may be important. Although I really believe that for the success rate of this PVC, some activation mapping is more important. So, which is the long-term success of ablation? This is a series that was published in 2001 with very good success rate at 15 months follow-up. And if we look at what are the symptoms, the LV dysfunction, the trigger, of course, we need to address this tachycardia. There are a lot of papers that have shown that success rate at long-term follow-up is pretty good, as shown in all these cases. Some authors have tried, here I summarize the success rate. As you can see, it's all high, especially when RVOT is the scenario. But we have open questions. So the reliability of LV function estimation in the presence of very frequent PVC is an issue. The prevalence of LV dysfunction in these cases, which are the factors predicting LV dysfunction, and the possible pathophysiological mechanism. Here, I try to summarize some studies that look at predictors, but none of them really was able to give good results in terms of giving us idea of what's going on. To conclude, in the last part of this presentation, I would like instead to talk about the patient with cardiac resynchronization therapy that have a lot of PVC or VT, and if in this case we are dealing with a tachycardiomyopathy or just with a lot of PVC. As we all know, cardiac resynchronization therapy increase or reduce mortality, and it's very important that the pacing, the bi-beat pacing, increase what is the survival in this patient, as shown in these studies. So, which may be the common causes of suboptimal percentage of biventricular pacing? Of course, we have several things: atrial fibrillation, ventricular tachycardia, and inappropriate AV delay, but PVC is usually the most important one. Why? Because the PVC, of course, reduce the biventricular pacing, and so reduce the possibility of the heart of being resynchronized. I found just one case report about this and the series that I'm going to present you, but I'm going to show you a case that was done in Italy. This is a patient of 63-year-old with a non-ischemic dilated cardiomyopathy, a left bundle branch block, symptoms in NYHA class 3, with the CRTD from 2005. In 2009, he developed heart failure symptom worsening. Why? Because of the presence of frequent PVC. Amiodarone plus beta blocker therapy was partially effective. In 2010, amiodarone-related hyperthyroidism became an issue, and so in 2011, an EP study and ablation was performed. As you can see, a lot of PVC here with a left bundle branch block morphology and inferior axis. From the ECG, we may see that there is an early transition before V3 and isoelectric in lead 1 and AVL more negative than AVR. So we may think this is a cusp morphology. I would like to show you which was the interrogation of the device, ventricular pacing 75%. And this is the echo pre and pre-ablation. Can you? Okay, thank you. With not a good synchronization of the ventricle, so ablation was performed. As you can see, minus 42 milliseconds was found in the area of the coronary cusp. This case was done in Italy, so intracardiac echo for cost issue was not available, and angiography was performed at our institution, as was said before. With the use of intracardiac echo, we almost never perform angiography. And here, during ablation, successful ablation, as you can see, PVC after ablation are not there anymore. And these are the movies of the pre-ablation situation where, as you can see, there is an improvement in the LV function. And looking at the pre-ablation and post-ablation percentage of bi-V pacing, as you can see, we move from 75 to 94%, which, of course, was important to restore the synchronization and the heart failure symptoms. So this is just to finish the presentation with this study that we did with Dr. Lucky Reddy, where ablation of this premature ventricular contraction was able to let patient non-responder to cardiac resynchronization therapy responders to that. So it was a prospective multicenter study with CRT patient with less than 5% increase or less than 10% left ventricle and systolic volume reduction, and no clinical improvement at 1 year follow-up, a lot of PVC in all these patients. These were the baseline characteristics. As you can see, the majority of patients were in class 3 on optical medical therapy. And you can see that the one morphology was the higher amount of PVC here. Importantly, as you can see here, pre-ablation and post-ablation, all parameters, ejection fraction, diameters, and volumes improved post-ablation. And these were importantly shown even in patients where we had a different type of burden of PVC. You can see that the best scenario was found when the highest number of PVC were present, where the improvement were higher in all the parameters evaluated. And this slide just show in a graph the correlation between the burden of the PVC and the post-ablation EF improvement. And here, instead, we see the correlation between the percentage of biventricular pacing pre-ablation and the improvement of EF post-ablation, as you can see is well shown here. So again, the burden is important because the majority of the improvement were found with a cutoff of 22%. As you can see, less than 22, more than 22, these were statistically significant in improving the response to CRT in these patients. And very importantly, this slide, as you can see, in 25 patients, pre-ablation, this was the EF, post-ablation, that was at 6 months follow-up, was the improvement. In this subset of patients, CRT was turned off, and as you can see, the EF dropped back almost to the same value pre-ablation. This is just to demonstrate that the number of PVC were not the cause of the tachycardiomyopathy, but was the absence of biv pacing that was the cause of the heart failure. Several sites, as shown before, were the origin of this PVC, and this is just from the paper one of this inferobasal area that was able that was the area of interest of this PVC. So in conclusion, although frequent PVC usually are a benign condition, in some instances they can cause left ventricular dysfunction or trigger malignant ventricular tachyarrhythmias. Premature ventricular contraction ablation in selected patients is feasible and effective. Successful ablation in patients with normal heart can reverse LV dysfunction, and successful PVC ablation in patients with the CRT can reverse response to CRT. Thank you very much for your attention.